Hello, my name is Dr. Anthony Kopp. I'm one of the physiatrists here at Mercy One Physical Medicine and Rehabilitation. Today we're going to be talking about an EMG. If you are referred to our clinic for an EMG, chances are one of your other doctors, or it may even be one of us, is looking for an issue with your nerves or your muscles. An EMG is really two parts: electromyography, where we use a needle to assess how well your nerve is talking to your muscles, and the second part is a nerve conduction study. So the nerves function essentially like an electrical cord. They have the plastic coating, we say, on the outside, which is called the myelin, and the inside, which correlates with the metal part of the nerve, is called the axon. Depending on how well the brain is communicating with the muscle, we can use the EMG to help determine if that pathway is completely intact. Usually we start with the nerve conduction study. So nerves transmit electrical signals. We use this device right here first we will have you, we warm the limb. You can use a correction factor as well if it doesn't reach a certain degree, but in our clinic we usually warm the limb, and that allows us to determine how well the nerve is conducting that electricity. So we use a stimulator, we stimulate the nerve, and we will have these spots measured out so that we can determine the velocity and how much of that stimulus gets transmitted along the nerve. So that can tell us how intact that nerve is. And it also, depending on how the results are, it can tell us if it's more of the plastic coating or the myelin that is injured, which is super common in something like a carpal tunnel, or if it's the axon itself, which we can see more in different neuropathies, or if there's like a pinched nerve up in the neck, we can see some changes as well. So first, as I mentioned, we use the stimulator to stimulate different nerves depending on your symptoms. And depending on what the exam shows, we may do more or less depending on the question that's being asked. After we have completed the nerve conduction test, we will transition over to the needle portion of the exam. Nerves are innervated like a muscle is innervated like a checkerboard. So each nerve is broken up into several fascicles that attach to different parts of the muscle. If you think of like a fiber optic cable, if there's an injury, it may affect only certain parts of that nerve bundle. Therefore, when we do the needle portion of the exam, we need to move the needle to different areas within the muscle to make sure we get a good sample. The first part of that, the patient stays completely relaxed. That allows us to have a nice quiet baseline. If the nerve and the muscle aren't talking to each other, the muscle sends up little help signals, and we're able to see that on the test. Depending on how long the nerve has been injured, that will look different on the EMG as well. So it can also help us determine how long a process has been going on. The second part of that EMG is where we actually have the patient activate the muscle, and there we're looking for the motor unit action potential. So depending on how those waveforms look, that also is very helpful to determine how long a condition has been present. If the nerve is completely myelinated with the same thickness of myelin and the axons are all kind of the same, that signal will get there about the same time. So it has a certain waveform. If that nerve has been injured and there's been some regrowing of some of those nerves to the muscles, it will go fast on some areas, but on some of those newer nerve sprouts, it will take longer. So then that waveform looks more spread out and more sporadic. Usually people tolerate these tests pretty well. At any time during the tests, we usually say, the patient's the captain of the ship. If they want to stop at any point, they can stop. But most of the time, people tolerate these pretty well. The level of stimulus that we use with the nerve conduction studies, we use the least amount of stimulus possible, but we need to ensure that we use enough to get a good signal. If you imagine the nerve as it's coming through your arm or leg, if we stimulate the nerve but we only get part of that nerve, let's say only a few of these fascicles, that may look like a smaller response than you actually have. So we need to ensure that we have enough stimulus to stimulate that whole nerve to transmit the signal. But we do try to use the least amount of stimulus as possible. And then for the needle portion of the exam, depending on what the muscles look like, if all of them look nice and clean, they all look normal, we often can do less sites or less muscles. As things are abnormal and the complexity of that build, sometimes we have to do more sites in order to determine where along that pathway could be a potential injury. Could it be pressure along the elbow? Could it be up in the neck? Could it be in the brachial plexus, which is like a nerve highway that supplies our hand? Or is it way down in the very, very distal aspect of that? So it's a very useful test. Usually people aren't signing up to do it every day, but usually people tolerate it pretty well. If you have any other questions, we can go over those when you get here for your appointment. Look forward to seeing you, and hopefully this puts some of your fears at ease if you have an upcoming EMG with us. Thank you.